We're going to work through reflux esophagitis, very common, how we manage that. Atrophic gastritis, we've touched on this morning, but when you biopsy and so on. Mike's going to look at cancer. David's going to talk about the technical aspects of retroflexion, which he did this morning, but we're going to go into a bit more depth. And my favourite topic is Seattle and Barrett. So we've got plenty to get tuned into. And as I say, if you want to post some questions, we'll do that. I'm going to invite Michael to speak first because he's then got to disappear and do a live case. So Mike, you're going to talk us through what I think I found cancer in the upper GI tract. What am I going to do next?
Well, first of all, I never think I found cancer. I know exactly what I'm looking at all the time.
We talk about a blink, Mike.
Yeah.
Do you have that programmed into you, the blink, like, oh my God, this is not looking good? Or do you still have a structured approach?
No, actually, I can just see out of the corner of my eye that doesn't look right.
Yeah.
Yeah. So if I walk in the room and the fellow's doing something, I can say, have you looked up there? But it comes with like lots and lots and lots,
Yeah,
but
absolutely.
Anyway, so the objectives, so we can identify what's endoscopically resectable and what's not. We need to take lots of biopsies to make sure we can secure the diagnosis if we think the lesion is not endoscopically resectable. And when in doubt, what's the appropriate approach. It's important, so there's data to show this. So in the colon, we know that pre-resection biopsies does not reliably detect advanced histology and large polyps. This has just come out in Endoscopy, at least it's online, and this is based on I think 600 cases or something, but basically in 40% of the cases the histology changes, and in 25% it's upstage. So, and it may make endoscopic resection more difficult. And we know this is the same for Barrett's neoplasia as well. It's basically a flip of the coin as to whether, based on biopsies, whether it becomes low grade or high grade or intramucosal cancer. So this is a meta-analysis of a lot of the studies, and we were one of the first to report this back in 2009 when Alan Moss was working with us. So there's a change in the diagnosis after endoscopic resection in 40% of cases, and this is because you're going to chop out the whole area, so that whole area of high-grade dysplasia there just goes. So it's not surprising that you get a much better result by endoscopic resection than you do by biopsy alone. They can also be an inflammatory fibroid polyp, which tends to be further back in the antrum here, often on the posterior wall. They can be quite bulky and look like a sort of mixed submucosal mucosal lesion. But here we don't see any intestinal. There's no endoscopic evidence of intestinal metaplasia in the antrum. And then if we look in retro, again we'd take. We need the motility to stop for a moment so we can find the incisura.
He just had some Buscopan.
Yeah. So somewhere in this region here we can get very good views, posterior wall, anterior wall, and if we see any sort of focal abnormality, then we can just zoom in on that and use near focus, and then we follow up carefully on the lesser curve side. Again, distend the stomach fully, and we can see that this fellow actually, he has a sort of hyperplastic polyposis phenotype of sorts, because he has similar lesions right up here in the cardia, just here.
So Mike, you're demonstrating fantastically there. The people watching are going to be thinking there's this big thing at the just prepyloric area, and the whole focus is going to be on that. And you just demonstrated you've got to look at the rest of the stomach. But developing Lob's point, if this patient's coming back with recurrent GI bleeding and you had to remove the polyp, how would you do that, given that they've had a previous ESD at that site?
Oh, I could show you just now, but it wouldn't take long.
No.
But look, the stomach here, right, so the antrum and the pylorus, they're super safe areas to do endoscopic resection. So I would just take a conventional snare. You'd inject, but you're not going to get much of a lift, and you may get lifting out here, which will make things more difficult, because this is obviously really tacked down. I would just take a 15 millimeter conventional snare and close around the base of the polyp, drag it into the stomach a bit, open a little bit, close back, and just make sure that we've got nice capture. and then I just top it off with conventional coagulating current, to be honest, knowing that it'll probably recur again.
Yeah.
So, yeah.
So your message, Michael, is don't cut it out unless there's bleeding.
Yeah, unless it's clinically indicated. So unless there's diagnostic uncertainty, which there isn't, because we know that the big specimen taken here before showed nothing, and we don't have a situation of recurrent iron deficiency or GI bleeding, so there's really no indication to remove this lesion, particularly in an older patient.
Good. No geeks coins for getting the answer right on this one.
But did we ask the question? After this.
After this. Next slide, please.
You can advance, I think.
Oh, I can advance. I'll do the advancing. There you go. So do you think yes? Do you think no? Of course, the answer is yes. As Michael ably demonstrated today, its points already been made today. You can only see what you know you're looking for. And if you're never looking for the ampulla, you're probably not aware of it unless it sort of pops out and hits you. And I would encourage you to look for it. In the same way as we've been referring to other areas of inspection today, it will delay your time in the duodenum and enable you to fully evaluate it. It's also, there's often motility here, and if it's really significant, you can consider the use of Buscopan to get rid of that motility. And the other thing you need to do is to clean and distend it properly. And really, the reason I changed the title is, the answer to this is yes. It's also easier with a cap than without a cap. And there's some merit to, if you've never used a cap, it's something you should probably get familiar with, which is going to come into my later talk when we're dealing with GI bleeding. And I think if you've never used one, it would be useful to understand how they work and what they add to your procedure. And I think certainly in viewing the papilla, it's a good way of doing that, but it's perfectly reasonable to do it with the standard scope most of the time. So I think it's best actually done with a side viewing instrument, which is why we have a different ERCP scope when we're doing biliary cannulation, but it can be done with a forward viewing scope. As I say, I mentioned the cap, and we need to keep everything slow. The take-home message here is not can you see the papilla, it's can you see everything else in the duodenum. And the duodenum, as you saw today with myself, is not always the easiest thing to get into. And it has you should really do everything on a direct control. And what you're really trying to avoid, which I demonstrated beautifully today, is the big red mark on the anterior wall of the duodenal bulb, where you've turned the corner. It's like you've banked the car up and turned the corner. You don't want to do that. You want to make the turn before you hit the wall. So your technique in terms of intubation is tip up, gently moving forward and then rotating in response to how the mucosa turns around. It basically tracks around and does a clockwise spiral maneuver to get from the pylorus into the second part of the duodenum. So when you're withdrawing, to enable you to see everything, you've got to do the reverse of that. So as you're pulling the scope back, two things happen. Firstly, you go forward because all the redundant scope in the greater loop gets pulled out. So you pull back, and if anything, you get paradoxical move forward. Then you one-to-one. So I see this a lot. You start withdrawing the instrument, nothing happens, so you pull it a bit faster, and as soon as you get one-to-one, you're back into the stomach. And if you had difficulty getting into pylorus of the duodenum the second time, you think, well, it's looked normal on the way, and I think we'll just keep going. And I'm just being real because that's what happens. So be mindful as you're pulling the scope out, you'll get paradoxical movement, the scope will straighten, and then you get one-to-one. Then you need to move really slowly, and you respond to the fold. So as the fold comes into view, so if it comes into view at 2 o'clock, you're going to move the scope down to 7 o'clock. You're going to go in exactly the opposite direction. And we're doing that by doing anti-clockwise torque, tip deflection down and withdrawing. So you use that combination of sequences in a normal anatomy, and you will be able to extubate the duodenum and ensure that you see everything, including the junction of D1, D2. And most importantly, if you're relating to big bleeds, it's often the posterior wall of the second part of the duodenum. So do this in a controlled and coordinated way, and you may need to adapt your technique if the anatomy has been distorted. And I don't just mean by surgery. Often following duodenal peptic disease, you get scarring and deviation, and just some people's duodenum's really straight and sometimes it's really angulated. And I think if you just do a blind maneuver, you're going to traumatize the mucosa. And I read when I was learning to endoscope, perforations of the duodenum were caused by just shoving the instrument straight through the back wall of the duodenum, trying to get around the corner. So I'd encourage you to do this under direct view and in a controlled manner.
Let's look at the poll answer. I see that no one's... Oh, some people have voted. Let's have a look. John, what is the answer to this?
This has got to be 97%.
It's 97% with a cap, and we wanted to end it like that. So please wrap up.